Are we ready?
I'm going live for the public now.
All right. Okay. Rajit, are you ready now? I can see all opening for the public now. Numbers coming.
Just wait a few minutes, so because
Yeah,
they are joining.
I can see that.
We can start at 4 sharp
I can
4:30.
see all opening for the public. May I start?
30.
Okay. Good evening. Greetings from Colombo, Sri Lanka. My name is Dr. UDP Ratnasiri. I'm the chair of the MFM Committee of AirFog. First of all, I must thank the President and the Council for giving me this opportunity to organize very important webinar on labor induction methods and how to use them in different settings. You all know the labor induction recommendations from WHO came first in 2011. It had been revised twice. So this is the latest recommendation or the recent update on this subject. So for this, we have three eminent speakers, one from WHO and other two are from my committee. And at the end of these lectures, we have a question and answer session. So please type your questions in the Q&A column to join at the end of the lectures for the discussion. And I have to thank the Sidus Cadilla Pharma and Rajitha Bandaranaike for sponsoring the Zoom technology for this webinar. And to start with, first of all, I must I invite Secretary General of AOFOC, Dr. Rohana Hattotur, to give the welcome address. Dr. Rohana Hattotur.
Thank you, Dr. Ratnasiri, for giving me this opportunity to speak a few words. And I welcome everybody to this webinar organized by the A4G committee on labor induction methods and how to use them in different settings. A WHO recent update. So I'm very happy to understand that there are more than 1,300 participants joining. So I welcome all the participants to this webinar, and I'm sure you will benefit at the end of this webinar very much. So I welcome you all warmly for this webinar. Then I would like to welcome our own Professor Pisek Lumbikanon, our president of the AFOG. I mean, he has been a live wire and he has been guiding us and advising us in all these webinars. And this is also is a initiative of Professor Pisek. As soon as all these new guidelines came, he asked Dr. Ratnasiri to organize this webinar. Then I would like to welcome our Dr. John Tate. He's from New Zealand, and we are very thankful to him for joining our president-elect of AFOG. It must be quite late in the night or early morning to him, but we are very happy that he is has joined the webinar. And then I would also like to welcome our Dr. Jaideep Tank, who is the YGA committee. He's a new formed committee in the AFOG, and he's a very lively person who is very helpful in our webinars and also a master of question and answer sessions. So you'll be you'll enjoy a question and answer session at the end of this webinar, towards the end of the session. Then, of course, as you know, the WHO has updated the recommendations, mainly on the timing of induction of labor, the use of mechanical methods of induction of labor, and the place of conducting the labor induction. So all these things will be discussed by our eminent speakers. So we have from the WHO, Dr. Chu Dorset. So we are very thankful for you and we welcome you for this webinar. And we are very thankful to you for joining. And then we have Dr. Preeti Kumar, who is also a member of our MFM committee of the AFOG. And also she's chairperson, co-chairperson in our SAFOG MFM committee. So he is also a very versatile. And then we have Dr. Sherry Ann Supildo from Philippines. And she is also a member of our MFM committee of the AFOG. So we welcome you for this webinar. And so these three speakers will enlighten us on this very important subject, because as you know, this induction of labor plays a crucial point in our cesarean section rates also. So we are very concerned, and that is also another thing our president has been looking into in this term. So to bring down the cesarean section rates. So the correct decision of induction of labor will also help us to reduce this in cesarean section rates. So without any, I welcome everybody once again to this session, and I hand over back to you, Dr. Ratnasiri, to continue with the rest of the proceedings. Thank you.
Thank you, Rohana. Thank you very much for your welcome address. And next I'll invite Dr. Professor Pisek Limnigon. He is the president of AFOG to give the introductory remarks on this webinar. Professor Pisek, please.
Thank you very much, Dr. Ratnasiri. Dr. Lohana Hatotua, Secretary General of AFOG, Dr. John Tate, President-elect of AFOG, Dr. Jaideep Tang, Chair of the Young Gynecologist Award Alumni Committee, Dr. Doris Chu, Medical Officer, Department of Reproductive Health and Research, World Health Organization Headquarters in Geneva, Switzerland, distinguished speakers, ladies and gentlemen, a very happy Chinese New Year to all of you. The implementation of evidence-based medicine in sexual and reproductive health practices is very important. AFOG strongly recommend evidence-based sexual and reproductive health practice in our region. The Department of Sexual and Reproductive Health and Research, the World Organization in Geneva, also recommends evidence-based sexual and reproductive health practices and regularly publish updated WHO recommendation following a very strict WHO guideline for guideline development. Pregnancy continuing beyond 41 weeks of gestation are associated with adverse outcomes for both women and babies. Women are more likely to require obstetric intervention, such as cesarean section, if their pregnancy continues beyond term. Evidence from a large systematic review show that after 37 weeks of gestation, the risk of stillbirth and neonatal death increased with gestational age. To prevent adverse outcome associated with prolonged pregnancy, induction of labor has been advocated. However, there are no agreed international standards for optimal timing and method for induction of labor. In 2019, the WHO Guideline Steering Group identified the recommendation on the induction of labor at term and beyond as high priority for updating. The decision was made in response to a significant change in the evidence base. In late 2022, WHO published the updated WHO recommendation on induction of labor at or beyond term. It is very timely for EOFOG to organize this webinar to inform our members the updated and evidence-based information on this very important issue of induction of labor. I would like to sincerely thank the EOFOG Maternal Fetal Medicine Committee under the leadership of Dr. Ratnasiri in organizing this webinar. Special thanks goes to Dr. Doris Chu, who lead the update of this important WHO recommendation and kindly join this EOFOG webinar even on Sunday today from Malawi. I wish you a very successful webinar today. Thank you.
Thank you, Prof. Pisek. I think now we'll go for the session for the speakers. So may I invite Prof. Pisek again to introduce the first speaker for the session, please.
Thank you very much, Ratnasiri. Dr. Doris Chu is currently a medical officer in Maternal and Perinatal Health Team, Department of Sexual and Reproductive Health and Research, the World Organization based in Geneva, Switzerland. And she was leading the update of this important recommendation by the WHO on induction of labor. So we have the right person to give us the first-hand information in this webinar. I cannot thank Doris enough for her kindness in working with us in this webinar. Over to you, Doris.
Thank you very much, Professor Pisek. And please, this is my privilege and my honor to be here with you all from AFOG. My greetings to all of you, to Dr. Ratnasiri, Dr. Hatanawa, Professor Tate, Dr. Tank, and my co-panelists, Dr. Priti and Dr. Sherry. It's really an honor to be here with you. I won't further delay, and I'd like to just share my screen. Hopefully this will work. Am I in full screen mode now?
Yes.
Wonderful.
Yes.
Okay. Thank you for your patience with the Zoom technology, and thank you for to our hosts for the Zoom links as well. Welcome to everybody. It really is a privilege to speak about the updated WHO recommendations on induction of labor. In my session, I will focus on the updated recommendations for the timing of induction, but my distinguished co-panelists will speak to the settings and also the use of mechanical methods. I don't need to tell this group in great detail that we are now in the era of the Sustainable Development Goals. And many of you and all of you know that since the year 2000, the world has been looking at how is health improving, specifically how is maternal health, maternal morbidity and mortality declining over time. The short story on this is we know what needs to get done in maternal health, but it's not being done enough. It's not being done soon enough or well enough. And so our chance to reach our goal for reduction of maternal mortality seems ever so elusive still, despite what we know. Many years ago, actually, we had the privilege to be in Thailand to discuss the strategies and targets on the Ending Preventable Maternal Mortality document. And this, together with the Every Newborn Action Plan, really comes together to describe for the UN what it is that we need to do to improve maternal and newborn health. And the discussion that we're going to have today is very much in line with this. Because as a matter of human rights, the highest quality of care is essential to reduce morbidity and mortality that is associated with pregnancy and childbirth. Of course, this means that we need to have up-to-date evidence. And for our discussion today, the question is, if there is a prolonged pregnancy beyond 41 weeks gestation, and as Professor Pisek has just mentioned, that there's an increased risk of adverse outcomes for women and their babies, what are we meant to do? I'd like to take a step back and perhaps describe to this audience how WHO actually updates recommendations. Because as Professor Pisek said, this is the firsthand knowledge. This is the information that is not always written and understood when you are reading a set of guideline recommendations. Basically, WHO and the team of maternal perinatal health has taken an approach to have a living guideline updating system. In other words, for the over 400 recommendations that we have related to maternal perinatal health, we are constantly scanning and very specifically and systematically looking at least once every 6 to 12 months, exactly what is and where are there new evidence points that we need to be aware of that may impact the recommendations that we have currently published. And so I have here for you on the slide the paper that describes the process on developing and applying the guidelines approach. This is by Vogel et al. And it really goes into how the updating system is looked at very systematically. And all of this is then referred to the WHO Guideline Review Committee, which monitors the guideline development process and makes sure that all the relevant regulations and standards are being applied to our work. As also mentioned earlier, this set of recommendations that we're discussing today has been previously published. And here, I just wanted to give you a graphic visualization of how this has happened. To the left of your screen in 2011, that was the first set of recommendations that was published with regard to induction of labor. And in 2017, the Executive Guideline Steering Group already said that there was need for an update. And so an update was made for the specific recommendation on the timing of induction of labor. And that was subsequently published in 2018. Again, when we went through the systematic review of where there might be new evidence, it became clear, as Professor Pisek said, that there was going to be new evidence coming out that might impact our recommendations. And so in 2019, our Executive Guideline Steering Group again recommended the prioritization of this review of this particular set of recommendations. And so what I have here for you is that showing that in 2019, 3 recommendations were requested to be reviewed and to be updated. That is for induction of labor at or beyond term, and the use of mechanical methods, as well as whether or not outpatient settings would be appropriate. Please understand that there are some principles for performing induction of labor, no matter where you are and in any setting. We should have facilities for assessing maternal and fetal well-being. And women who are receiving any type of inductive agent should never be left unattended. And of course, wherever possible, induction of labor should be performed and carried out in facilities where cesarean section can be performed if needed. Here are the 3 publications on the recommendations that were updated in October 2022. I'm going to speak to the one on induction at or beyond term, and my colleagues will discuss and present on mechanical methods in outpatient settings. The scope of the recommendation, or the scope that was being looked at, was to ask the question, in pregnant women at or beyond term, Does induction of labor compared with expectant management improve maternal and perinatal outcomes? And the idea was to really contextualize this for clinical practice, to understand this in the context of hospital settings, and to review against specific outcomes for the mom and the baby, such as whether or not cesarean section was needed, whether or not there was the woman experienced hyperstimulation, and for the baby, Apgar scores that were less than 7 at 5 minutes if they were admitted to the NICU. These are the types of outcomes that were looked at. Of course, you can read this all in the document as it has been published in Annex 2. Again, I'd like to go back and give you some of the background information on how these recommendations are formulated, because I'm not sure that when you read the document as it is, that some of this comes to life. It's hard to describe the debates that take place during a guideline development meeting. But let me just summarize to say that as part of the Secretariat, WHO puts together what we call the evidence to decision framework. And this is the summary and amalgamation of all the evidence that the guideline development group will consider in its formulation of the guideline. And what the guideline development group will be looking at is the evidence of effects, the values and preferences of women and their providers, the acceptability for women, the feasibility for the intervention, and the resource use and costs, as well as impact on equity. And so although you see the web annex there on your top right corner of this slide, I refer you to 2 documents that actually inform that evidence and decision framework. The first, I think you would all be aware of, which is the Cochrane review that was published that informs this induction of labor at or beyond 37 weeks gestation as a systematic review. But some of you may not be aware of this other paper by Morano et al., of which I am a co-author, which describes how we use the WHO integrate evidence decision framework to develop the recommendations for induction of labor. And so I would urge all of you, or any of you who are interested in the nitty-gritty of how we came up with these recommendations, to look not only at the evidence to decision framework, but also at these 2 source documents. I'm going to summarize here for you and give you sort of a bit of a hint. The main question that we looked at for our guideline recommendation was to actually divide and ask, is there a difference for induction of labor at less than 41 weeks or greater than equal to 41 weeks gestation? And so what I'm showing you here is a summary table of what the GDG actually had to consider. So they considered what were the desirable effects or the undesirable effects of the intervention? What's the certainty? How sure are we of the evidence? And what about the values and preferences? And here, to understand the values and preferences, it's not just the woman's perspective, but it's also looking at, then we move on to a balance of all the effects, the resources that are required, and the evidence, the certainty of the evidence on the resources, as well as equity, acceptability, and feasibility. Now, just to say, you can read in the evidence decision framework all about the Cochrane review from 2020 that includes more than 34 trials with over 21,000 women from 17 countries. You can read about the fact that 2 of the studies that are included in this Cochrane review actually come from Thailand. So you can feel that there is that the information and the evidence is applicable to your settings and actually a global setting. The next thing I want to inform you on in looking at this is, if you see, I have put blue boxes around the summary of judgment table. And anybody who looks at these summary of judgment tables, your quick hint of what to do with all this information is to say, the more that you have check marks towards the right-hand side of this box, or the skinnier that this box is, the more likely that we are going to recommend that intervention. Whereas the further you go left in these summary of judgment tables, where you see things like don't know, no included studies, it means that there's either very little evidence or there isn't much to sway one way or the other for an intervention. So a very quick look at these summary of judgment tables will help you in understanding why a GDG has made a recommendation one way or the other. So here, just looking at the summary of GDG judgments, you can see that for less than 41 weeks, that box is rather wide, whereas for greater or equal to 41 weeks, that box is a bit narrower, focused on to the right side. So this leads to the recommendations as they have been published. There are two. The first recommendation is that induction of labor is recommended for women who have a known certainty to have reached 41 weeks. And this is moderate certainty evidence. Again, so you see on that bottom right-hand corner there that that box of blue is a bit narrow and towards the right. The second recommendation is that routine induction of labor for women with an uncomplicated pregnancy at less than 41 weeks is not recommended, and that's low certainty evidence. Again, this is reflected in the fact, if you look at that bottom left-hand corner, that box is wide and it's moving towards the left-hand side, which has a lot of I don't knows, okay? Again, I want to focus on the GDG's thinking on this. One, you saw that there is mention for known gestational age. I'd like to remind the audience that WHO recommends one ultrasound scan before 24 weeks gestation is critical to estimate gestational age. In addition, improved detection of fetal anomalies, multiple pregnancies, and to primarily avoid induction of labor for a poorly dated pregnancy. Also, the GDG consider that most women will actually give birth by the end of the 41st week of gestation. And so spontaneous labor will minimize interventions, minimize the potential for over-medicalization of what is a physiologic process and may lead to a more positive experience. The GDG did weigh the fact that, of course, there was a large study from a high-income country, particularly the US, that showed that there was a moderate level of benefits for low-risk women who underwent induction of labor at 39 completed weeks of gestation. But they cautioned that any perceived benefits might not be generalizable to lower resource settings. So the GDG made a very clear statement here. In a setting where induction of labor can be carried out safely, a woman with an uncomplicated pregnancy at 39 at full term, considered to be 39 weeks and up to 41 weeks, could consider induction of labor in the context of their values and preferences. This would be a joint decision-making process between her and her care provider, but this could only be done in settings that is able to provide midwifery care, fetal heart rate monitoring, immediate access to cesarean section, and if needed, access to pain relief. So the GDG was very careful to make it clear. This is not something that is meant for every setting. The GDG wanted all implementers and adaptations to include that an indication for an induction of labor must be documented. And that includes what the clinical indication is, or if it's being done at maternal request. And of course, high quality antenatal care and fetal surveillance should continue until the onset of labor or induction. And the GDG wanted to remind that these recommendations pertain to women with uncomplicated pregnancies. Because of course, if there's a complication in the pregnancy, then other means would need to be considered. How do we put these guidelines into practice? Well, I think you're doing something right now today, that is disseminating these updates. But also, I think my co-panelists will be speaking about adaptation and what this means in terms of how are we going to look at gestational age assessment? Is there an environment that permits this? Even the counseling for how to consider when and whether to do an induction. And again, how are our health workers able to manage these interventions? The GDG also came up with some questions and identified some research priorities. Fundamentally, we actually don't have very good information on how often induction of labor is successful. And the other thing is, can we come up with a risk stratification that is more customized for a woman based upon her gestational age and based upon where she is meant to deliver? I'm going to close here, but before doing so, I'd like to extend acknowledgements and thanks because I'm presenting on behalf of a great many number of people, including the Guideline Development Group, the External Review Group, my Systematic Review Team, our observers to the process, and of course, our funders, the USAID and our Human Reproduction Program at the WHO. So thank you, and over to you. Thank you.
Thank you, Doris, Dr. Doris, for excellent presentation and highlighting why we need to induce at 41 weeks and beyond, and what are the desirable and undesirable effects if you induce it before. And I think, we all are impressed with your presentation, and I think, we will have more questions and you have to answer at the end of the session. So please type questions for her to answer at the end of the session. Please remain joined for the session, please. Thank you. So may I invite Dr. Rohana Hattu to introduce the second speaker for the series, please. Dr. Rohana Hattu.
Thank you. Okay, it's my pleasure to introduce Dr. Preeti Kumar. As you know, Dr. Preeti Kumar is also the chairperson of the Safe Motherhood Committee of FOGSI, and also co-chair in the Maternal and Perinatal Committee, SAFOG, and committee member of MFF Committee, AFOG. I mean, she has been doing so many programs in the SAFOG on postpartum hemorrhage, and he has taken it to not only in India but also into other countries in the SAFOG region. So he's a very active member in this maternal fetal medicine committee. She is also professor and head in the Narayana Institute of Medical Sciences, Kanpur, India, and the organizing secretary of the UPCOG 2023, and has been the organizing secretary of the AICOG, which was held in 2020. So I would request Dr. Preeti Kumar to kindly deliver her lecture that is on mechanical methods of induction.
Thank you so much, Dr. Rohana sir. Namaskar, and I bring greetings from India. And thank you for the kind words. And let me share my screen first. So are my slides visible now?
Yes, yes.
Thank you so much. At the outset, I would like to thank Professor Pisak, Professor Rohana sir, and Professor Ratnasiri sir for giving me this opportunity to speak on mechanical methods of induction of labor. After listening to Professor Doris, the first-hand information from WHO, I would be presenting rather what I have read from the WHO recommendations. And I would also like to share my experiences, what is feasible in our country, because we understand that every country has its own challenges and every country needs to understand their own solutions also. So the primary goal of the present guideline is to improve the quality. Just a minute. Yeah, the primary goal of the present guideline is to improve the quality of care and the outcomes of the pregnant women under the induction of labor in the under-resourced settings in a country. So the contents of my presentation would be introduction, scope of recommendations, support evidences, implementation, and challenges, and what are the researches and the way forward. So WHO envisions that a world where every pregnant woman and a newborn receives the care throughout the pregnancy should be free of complications, not only in the childbirth, but also in the postnatal period. And to have the sustained development goals, the high quality maternal health care for women is very important and necessary step towards the achievement of the health targets and indicators. So how we define induction of labor is a process of artificially stimulating a labor prior to its spontaneous onset and ultimately achieving the vaginal delivery. And we know that we should the way the risk versus benefit ratio, and the induction of labor is only recommended when there are clear indication and induction poses the continuation of the pregnancy poses a greater risk to the mother and the newborn. So health practitioner must balance the risk and the benefit ratio for the continued gestation and induction of labor to maximize the maternal and perinatal outcomes. These are the general principles. I think Doris has already mentioned about it, so I'll skip this slide. And so methods of induction have been pharmacological or mechanical, and some have classified as a non-pharmacological because the sweeping and ARM are the two things that we usually put it in non-pharmacological here in India. But for pharmacological, we have prostaglandins, mifepristone, and oxytocin. And for mechanical, mostly what we use is Foley's, or laminaria tens. So scope of recommendation had been on the PICO format, where the population, intervention, comparator, and outcomes have been seen. And in pregnant women at or beyond, in this mechanical induction of labor, do mechanical induction alone or in combination with pharmacological method, as compared to other types of induction methods or no intervention, improve the maternal or perinatal outcomes. The outcome measures were on the maternal and the fetal part. The maternal were vaginal delivery not achieved within 24 hours, or cesarean section or uterine hyperstimulation with fetal heart changes, postpartum hemorrhage, uterine rupture, or severe maternal morbidity. And for the fetal and neonatal, ABGA score, admission to the NICU, neonatal encephalopathy, and these other things were seen in the neonatal outcome. Now, this is the recommendation which was put forth in 2011, where it was recommended that balloon catheter is recommended for induction of labor, and this was moderate quality evidence. And combination of balloon catheter plus oxytocin is recommended as an alternative method when prostaglandins, including mifepristone, misoprost, is not available or contraindicated, and this was a low quality evidence. Now, this is the recommendation that has been put forth by the WHO in 2022, that balloon catheter is recommended for induction of labor, and this is a low certainty evidence. There are multiple induction. Am I slides visible?
Yes,
Yes, you can see. Yeah, nicely
Yeah.
you can see them. Yes.
So I because I can see, so I'm just keeping it like this. Is it visible now?
Better to have the full screen, is it? Okay.
Just a minute, sir.
Right, it's good.
So the 2022 recommendations, where there are multiple induction methods, both pharmacological and mechanical. The choice of induction method should be discussed in context of antenatal care, and taking into consideration the values and preferences of the women, the potential of fetal risk, and availability of accessibility of different methods in particular setting. As an induction method, the use of balloon catheter for induction of labor may be particularly useful in situations where it would be beneficial to avoid uterine hyperstimulation, or when the use of prostaglandins is contraindicated. The recommendation 2 was the combination of balloon catheter plus oxytocin is recommended for induction of labor. That was low certainty evidence. And the remarks that were given were that the studies and the systemic reviews define the combination of balloon catheter plus oxytocin as concurrent use of balloon catheter and oxytocin. All the sequential use of balloon catheter followed by oxytocin is also in common use. In general, there is a lack of evidence on combined evidence. Now, the summary of evidence, the evidence of the effectiveness and the safety of mechanical methods for the induction of labor was derived from Cochrane Systemic Review updated in 2019. The review included 113 trials. The data on relevant outcomes from 105 studies with the total of 22,373 women. The review examined 4 broad types of intervention: the balloon catheter versus other intervention, other mechanical or pharmacological or mixed, laminaria trunk versus other intervention, extra amniotic infusion versus other interventions, any mechanical method combined with another like non-medical or mechanical or intervention versus other intervention. Out of 22 comparisons made, 18 of them were relevant to PICO for this guideline and were presented to GDG. Now, coming to the mechanical induction of labor, this is the largest Cochrane library and here the study was done to determine the effectiveness and safety of mechanical methods for 3rd trimester beyond 24 weeks of gestation, induction of labor in comparison to prostaglandin E2, vaginal or cervical, low dose misoprostol or amniotomy or oxytocin. Here, the mechanical methods which were included were the introduction of catheter through the cervix into the extra-amniotic sac and balloon insufflation, introduction of laminaria trunks or other synthetic equivalents like dilapam. We did a study also in one of the medical colleges here into the cervical canal, and use of catheter to inject fluid into extra-amniotic space. Now, the review comparisons were the specific mechanical methods, balloon catheter versus laminaria tent or EASI, compared with prostaglandins, different types, whether you are using vaginal or cervical or with oxytocin, single balloon compared with double balloon, addition of prostaglandin or oxytocin to mechanical methods compared with prostaglandin or oxytocin alone. Though the certainty of evidence is that for most comparisons and outcomes, the evidence was low or very low certainty with little or no difference between the groups. The majority of the evidences on effectiveness compared the use of balloon catheter with other methods, and mechanical induction with the balloon catheter is probably as effective as induction of labor with vaginal PGE2. So the difference was not much, and maybe with a few adverse side effects, and the certainty of evidence was low to moderate. When balloon catheter was compared to the oral misoprostol, it was found that it may be slightly less effective as an induction method compared to oral misoprostol. But it remains unclear if there is a difference in safety outcomes of the neonate, and this was a moderate quality evidence. When compared to low-dose vaginal misoprostol, a balloon catheter may be less effective, but probably has a better safety profile, and this was a low-quality evidence. Balloon catheter probably reduces the risk of cesarean section when compared to oxytocin, and this may also be a case in women with previous cesarean section. And we also in India use most of the times, majority of the times, the balloon catheter. Now, when we talk about the balloon devices, for why we use Foley's in a low resource country like ours, because it is safe, cheap, easy to store, preferred in cases of scarred uterus because of the hyperstimulation. When the induction of Foley's is contraindicated, as a contraindication to such is the rupture of membranes, we know that suspicion of chorioamnionitis, even with the intact membranes or lower lying placenta, and relatively contraindication in abruptio. How to insert the catheter position is dorsal position, thighs flexed, aseptic techniques. Preferably, we use 16 French catheter. Anterior lip is held with the cervix or held with the sponge holder. And Foley's is held either with the instrument preferably and push the balloon above the internal os. Inflate the bulb with 30 to 60 ml of saline. The traction is given so the bulb is at the level of internal os, and tie the Foley's at the thigh. Leave it for 12 to 24 hours until she expels, whichever is earlier. It should be deflated or removed with the labor begins, so membrane rupture or spontaneous expulsion of device happens. Now, there are few studies which I want to quote here. The amount of saline to inflate the Foley's balloon. The balloon volumes larger than 30 ml during Foley's catheter induction reduces the total time to delivery by approximately 2 hours. This study has been done by Corina, and this may be preferable for women undergoing labor and induction and could impact the complication associated with prolonged labor induction. Now, there is another comparison where intracervical Foley's catheter balloon versus dinoproston gel. Here, they have mentioned that intracervical Foley's catheter balloon was efficient as a dinoproston insert. Additionally, there was no significant difference between the two methods regarding the maternal and neonatal safety. Now, again, coming to another study which has been again done using the double versus single balloon catheters. Again, the conclusion was drawn that the both kind of balloon catheters have similar level of efficacy, efficiency, safety, and patient satisfaction. However, the single balloon method is considered to be more cost effective. Another study which has been done comparing, this has been published in Medical Journal 2018, comparison between the transcervical Foley's catheter with oxytocin versus oxytocin alone in inducing the labor. Here it was found that there is no significant fetal and maternal complications, and transcervical Foley's catheter probably is most useful method for ripening before induction of labor. Using transcervical Foley's catheter with oxytocin had a highest rate of successful induction with the least dose and duration of oxytocin required, which was very significant. Another study using transcervical Foley's catheter and oxytocin compared with transcervical Foley's catheter alone for induction of labor. Here it was seen that concurrent use of oxytocin at the initiation of induction of labor exposes to a longer duration of oxytocin without expediting the induction, thereby questioning oxytocin's efficacy on the unprimed cervix. Thus, concurrent methods, Foley's or oxytocin, offers no extra advantage over the conventional methods like Foley's catheter alone for induction of labor. This is a study which we have also done at KGMC. Here, the Dalapam, which is a vaginal hygroscopic dilator versus Foley's catheter, and here also the maternal and neonatal adverse events were not significantly different. Now, coming to the implementation, again, this is important to ensure the accurate assessment of the gestational age, as mentioned by Dr. Doris. Now, again, healthcare workers in antenatal care settings require supportive supervision for dating ultrasound, but in our country, the healthcare workers do not perform ultrasound. Health professionals will require training to counsel women on the benefits and side effects of different methods for induction of labor, and women should be adequately counseled and engaged in shared decision making. But still, the question is whether actual use of oxytocin should be concurrent or sequential still needs more research on mechanical induction of labor. So the last slide would be take-home message. Mechanical methods are effective, comparable to prostaglandins, equal rate of cesarean deliveries compared to use of prostaglandins, reduce frequency of uterine hyperstimulation and reduce risk of fetal heart rate abnormality with mechanical induction of labor, reduction of the risk of cesarean deliveries compared to use of oxytocin. It has better safety profile in women with previous cesarean deliveries and shorter hospitalization and lower cost compared to medical induction. So thank you so much for patient hearing. With this, I end my presentation.
Thank you, Preeti, for your excellent presentation on methods of induction, comparing different methods and what to use in different settings. I hope that there will be more questions on you at the end of the sessions with this kind of, different methods which we are using for induction, sometimes combination, sometimes differently, and all this. So please stay.
I'm sorry, sir, for the disturbance that happened in between. Sorry.
Okay,
sir.
thank you. So may I invite the next speaker? I'll invite Dr. Jadip Tank, chairman of the YJ committee, to introduce the next speaker for our session, Dr. Sherry Ann Supildo. Jadip, I think you're there.
Thank you. Thank you very much, Dr. Ratnasiri. It is a pleasure and a privilege really to be here. And it is my great pleasure and privilege to introduce Dr. Sherry Ann Sulpido, who is a maternal fetal medicine specialist and a clinical associate professor in ONG at the Philippine General Hospital at the University of the Philippines. And it's also a member of the MFM committee of AOFOG. And we are looking forward to hearing from her on the outpatient settings for induction of labor. The stage is yours, Sherry.
Thank you very much, Dr. Tank. And let me just share my slides. Happy New Year, everyone. And thank you very much, AOFOG. Thank you also, Dr. Ratatua, Dr. Lumbiganan, Dr. Ratnasiri, Dr. Tate, Dr. Tank, my co-speakers, Dr. Kumar and Dr. Chu, for this opportunity to give you an update on the 2022 World Health Organization recommendations on outpatient settings for induction of labor. Greetings from the Philippines. Good evening. Are my slides seen, Dr. Tank?
Yes, there.
Thank you. So of course, as if you are a healthcare provider, whether you're a midwife or a general practitioner, an obstetrician gynecologist, or a maternal fetal medicine specialist, it's always our duty to provide high quality health care for our pregnant women, for us to be able to reduce adverse perinatal outcomes, maternal morbidity, and mortality. And with this, so we take care of our patients actually preconceptionally, antenatally, when we go to the clinic for prenatal checkups, intrapartum, which is very important, and even postnatally. So once our pregnant women reach term gestation, so we also always have to weigh the risks and benefits of prolonging the pregnancy, or does she have an indication for delivery, early delivery. So as Dr. Chu very beautifully emphasized earlier, as seen in our WHO guidelines, induction of labor is recommended only if there is a clear indication. So at or beyond 41 weeks, or if there's a medical indication, if prolonging the pregnancy there's a risk in the mother if we prolong the pregnancy. And we still follow the following principles, that we have to carry it out in a facility where we are able to monitor our patients well, assess both the mother's well-being and the fetus, and whether they're receiving any uterotonic like oxytocin or prostaglandins. We should always monitor them, and they shouldn't be left unattended. And this, when we are to embark on induction of labor, they have to be carried out in a facility where you are able to perform, of course, an emergency cesarean section in the event of a non-reassuring fetal status or a failed induction, for example. So usually, induction of labor takes place in a hospital, in a birth center, or in a midwife-led unit. But currently, there's growing evidence that what about sending our patients home? Can they be induced at home, where they can walk around, they are able to have control, and they have autonomy, and they're more comfortable with their family support? So when we say outpatient induction, this is defined as induction at home. But induction here means priming of the cervix generally. So usually, as I've mentioned, most of our patients are being induced in the hospital. But we surmise that when the patient is at home, she might have a better or a satisfying and positive birth experience, because she can eat whenever she wants, she can walk around, she can assume any position. Actually, we're trying to simulate some form of normalcy, even if the patient is in the hospital. We try not to insert an IV line, we try not to put her on NPO and the like. But of course, it's still different when the patient is at home. She may be at home when she's at home. So, as I've said earlier, women are induced at home or in the hospital, but mostly they go to the hospital, or they can start induction or cervical priming in the hospital, where initial assessments on the maternal and fetal well-being can be done, and then they can be sent home first. If their cervix is undergoing priming, they return home, and once there are regular uterine contractions or there's active labor, they are advised to go back to the hospital. So why did we come up with this guideline? So Dr. Chu also beautifully told us about the rationale of having updates by the WHO, and we'd like to thank them for that. In 2019, the Guideline Development Group prioritized three topics that we want to address for 2022, for this year. So these are the following, and this is the reason why we're having this webinar series, and one of which, so having induction of labor at or beyond term, which we heard beautifully from Dr. Chu. We heard also from Dr. Kumar the use of mechanical methods for induction of labor. And now this lecture will be dedicated to the use of the outpatient, or is there any benefit if we do home or outpatient induction of labor compared to inpatient? So we come up with guidelines because there's emergence of new evidence. So we'll be able to tackle that in the following slides. So we found out that there were additional randomized controlled trials comparing home induction and inpatient induction. And we want to see if there is any change or any improvement or any impact on the clinical outcomes for both the mothers and the baby. So this definition has been clearly stated by Dr. Kumar earlier, that sometimes our patients are indicated to undergo induction of labor, especially if there's an indication or we want to artificially start uterine contractions if they have a medical comorbidity or they're at or beyond term or they're post-dated. And we always weigh the risks and benefits of prolonging the pregnancy. If we prolong the pregnancy, will it benefit the mother, or does she warrant an earlier delivery for them? So sometimes you fail to take into consideration how the mother feels. So induction can be very challenging, not just on the obstetricians, but also or on the healthcare providers, but also on the mother. So she may feel uncomfortable, the uterotonics are quite painful. And in the hospital, we try to provide continuous maternal support, but of course at home, she'd have more support with her family. And when you're in the hospital, you're in the bed, you might feel that you don't have autonomy or you lack the control. So there may be some benefit to having home induction. It may improve and the patient can have a positive birth experience, she may be satisfied with her labor. And in addition, there is a reduction in the length of stay in the hospital. So it also will reduce the cost for the patient. So it may be cost effective to do home induction of labor. But of course, we have to take into consideration not just the efficacy, but the safety for both the mother and the baby. Because at home, we're not able to monitor her as much as we can compared to if she's in the hospital. But for the purpose of this lecture, when we say home induction, we mean cervical ripening, actually agents before formal induction of labor. And there are only a few agents that we can use, and that would be insertion of vaginal prostaglandins or insertion of the Foley catheter, wherein we heard Dr. Kumar mention it earlier on how to do Foley catheter insertion. So the question that we want to address in this third lecture is, among pregnant women requiring induction of labor, will outpatient care or home induction of labor compared if they are admitted or inpatient care improve birth outcomes, maternal and perinatal outcomes? So of course, in every guideline, the first thing we have to do is gather evidence. And there is a update, a meta-analysis just this 2020 with the addition of 3 randomized trials by Alfirevic and his colleagues, assessing the effects on neonatal and maternal outcomes of third trimester home induction compared with inpatient induction using the same methods of induction. So in this study, we will be seeing the use of vaginal prostaglandins and or the Foley catheter. So in this Cochrane review, there were 7 randomized trials, 6 of which provided data for more than 1,600 women. And this was conducted between 1998 to 2015. And I think it's pertinent to mention that the population of pregnant women here were from high to upper middle income countries. And the indication for their induction they are post-dated. However, I'd like to emphasize that the most of the grade assessments here were of low certainty evidence because of imprecision and high bias. So there are 3 groups of different randomized trials seen in this meta-analysis. The first group would be comparing home versus inpatient induction with the use of vaginal prostaglandin E2, which is the dinoprostone. In the Philippines, we also use cervical gels and pessaries in the form of dinoprostone or prostaglandin E2, as misoprostol is not, the use of misoprostol in our country is illegal. So if there are 2 randomized trials using vaginal prostaglandin E2, and they made the patients answer a survey, and although there was some satisfaction in having their induction at home, some patients preferred to be induced at home. However, the evidence is very uncertain, and there is just a slight satisfaction among these women. But if you look at the primary outcomes, and these primary outcomes are the following: likelihood of a successful vaginal delivery, rates of cesarean section, uterine tachysystole, adverse neonatal outcomes like sepsis and admission to the NICU, based on very low certainty evidence, there may be little or no difference whether you induce at home or do it inpatient. And when I say at home, the patients go first to the hospital, the methods are administered there, and then they go back home for their ripening, and they just go back to the hospital when there is active labor. The second group of patients in this meta-analysis compared the home induction versus inpatient induction with patients receiving a controlled release prostaglandin E2, still in the form of dinoprostone, as a pessary. So this involves around 300 women. And unfortunately, the validity of the questionnaire is being questioned. So there is really no, we cannot really surmise whether or not there was a overall, the patients who were induced at home were satisfied. And in terms of the primary outcomes that I mentioned earlier, uterine tachysystole, rates of cesarean section, likelihood of a successful vaginal delivery, and adverse neonatal outcomes, there was also no difference, very little or no difference, based on very low certainty evidence. The last group compared home induction versus inpatient induction with the use of the Foley catheter. So This includes 4 randomized trials, but I think only 3 out of which had good data for of 289 women. So the questionnaire is the questionnaires to ascertain the satisfaction of the mothers turned out to be unclear. And in terms of the primary outcomes, like the first 2 groups, there's also very low certainty evidence that home induction reduces the primary outcomes such as cesarean section rates, or will there be an improvement in the rates of vaginal delivery? Is there a decrease in uterine hyperstimulation and adverse perinatal outcomes? So the authors of this 2020 systematic review concluded that the data on the effectiveness, safety, and women's experiences of home versus inpatient induction are very limited, and the evidence is very of low certainty. So maybe more instead of just including randomized trials, we can include large observational cohort studies. I know it will kind of decrease the level of evidence, but maybe large observational cohort studies can help in terms of seeing if the patients are more satisfied or if there is improvement in birth outcomes. So based on this 2020 update and the addition of 3 randomized trials on the study, the World Health Organization deemed it appropriate to have an update on the recommendation of outpatient setting for induction of labor. So based on Dr. Alfira Vic and his colleagues, they based the update on the 2020 systematic review with the use of certain methods like vaginal prostaglandin E2 or dinoprostone, pessary, and 3 studies on the use of the Foley catheter. So I guess these patients were first seen in the hospital, then the Foley catheter was inserted, left for 12 to 24 hours. They were sent home first, and then they were going to go back the day after 24 hours or when active labor starts. They tried to compare home induction versus inpatient induction. And based on the systematic review, the WHO also recommends that routine outpatient induction of labor is not recommended for improving birth outcomes. And this is based on low certainty evidence. So with this recommendation, you also have to take note of certain considerations. So I mentioned earlier that the population for this Cochrane analysis is based on pregnant women from high income and middle income countries. So maybe the circumstances would be different from low resource countries like ours, like the Philippines. And then you also have to take into consideration that depending on how the patient was counseled, so it should be an informed choice, and there should be a shared decision between the healthcare provider and the patient whether or not it's going to be beneficial if she's sent home for induction of her labor, and what are her preferences. You also have to ask her about it. And of course, this also can be an option, although there is based on very low certainty evidence that the WHO does not recommend outpatient induction of labor, have to take into consideration the circumstance of the patient situation So, for example, it's low resource, she's low risk, she lives near, she's able to transport to the hospital with no difficulty, or she has good family support, or the facility there's good manpower that the facility can do home visits while the patient is at home, she has good family support, then maybe it can be an option for these patients, depending on how you counsel this patient and how if the patient prefers. So wherever and feasible, I mentioned earlier that it has to be a shared decision making. The patient is informed of all her choices. She's informed of the risks and benefits and the method for induction. And if you're able to embark, or you decide to embark on home induction of labor, then there should be a proper protocol. There should be a well-organized program, adequate manpower. There is resource on how to remotely monitor our patients. I know that in some countries, like in Japan, they are very much promoting their remote wireless cardiotachographic machine, wherein the patient can self-administer the probes, and then the data are transmitted into a cloud, and the physician or the midwife or the healthcare worker can see the traces or the interpartal monitoring while the trace is ongoing, or it's in real time. So you're able to detect whether or not there is a non-reassuring fetal status. So it's like having the patient in the hospital as well. So I think it really depends on the setting for your patient. So the challenge remains. So as healthcare professionals, we should be always updated, and we really require constant training on how to counsel our patients on the benefits and risks and side effects of induction in general, on the methods used, and whether or not she wants it inpatient or outpatient. They have to be adequately counseled and engaged. I cannot overemphasize that it should be a shared decision-making between the healthcare provider and the patient as well. We have to take note that, of course, there are settings wherein our patients come from low and middle income countries, and they require more manpower, and that is the usual problem. So regardless of whether if they're in the hospital or at home, we should be able to provide the necessary level of support, be able to assess and monitor them, so that in the event of adverse outcomes, we're able to intervene earlier. We also, the challenge also remains that there is, since most of our patients are induced in the hospital, manpower is still a problem, resources is still a problem, and this always has implications on the distribution and productivity of our healthcare professionals, especially in low resource settings. So we have to be able to ensure that when we do embark on induction of labor, we have to be able to have access, and our patients have access to full and timely information. So counseling is very important. And this is where social media comes into play. Because of social media, we have the necessary information, but we also have to be very discerning when it comes to choosing which information to read and to believe. So social networks can assist our patients to understand the information if needed. And she has to be aware and made possible by the provider. She's aware of her needs, values, and preferences as well, because always the ultimate goal of every physician, healthcare worker, a specialist is a safe vaginal delivery with favorable outcomes for both the mother and the baby. Thank you very much for listening, and take care.
Thank you very much, Dr. Sherry, for your excellent presentation, clear, excellent presentation. I think, now different settings, different, practices, but, at the moment, WHO doesn't recommend outpatient inductions in our settings. I think, there may be more trials and more studies to come. So I think we'll wait for them. And at the moment, so we avoid the inductions as outpatients. So I think, I thank all three presenters, for their excellent presentations. I think the time now is for question and answer session. So may I invite YGHR, Dr. Jaideep Tank, to conduct the question and answers. And I can see a few questions on the screen. So please, Dr. Jaideep, take over the session, please.
Thank you very much, Dr. Ratnasri. And I think I request the admin to have everybody's video together, so that, because questions will be addressed to all the speakers. So let's not spotlight any particular speaker, so that the audience can see everyone in the panel. And I'd request everyone in the panel to please keep their video on. And if even the Professor Pisek, Dr. Rohana, or John have any inputs on the questions, please feel free to go ahead and ask them. Doris, I'd like to start with you and, sort of take you back to what you presented about induction from 39 to 41 weeks vis-a-vis after 41 weeks of induction. And if I remember right, the Cochrane review, which was authored by Middleton et al., talked about induction from 37 weeks onwards, vis-a-vis, in expectant management. So, I mean, why is there this sort of discrepancy, if I may say so, where that Cochrane review talks about 37 weeks onwards, and the WHO recommendation talks about 39 weeks onwards? What is so special about this 37 to 39 week interval? Or is there a lack of evidence which says that don't do it at 37, wait up to 39?
Thank you for the question. And in fact, this was something that came up in that the Cochrane Review underwent a specialized sort of rewriting and regrouping for gestational ages into subgroups for the purposes of the recommendation. There are a couple of issues here. One, this concept of gestational age dating was an issue. As mentioned, some of the papers included in this systematic review, although half were published after 2010, there are quite a few that came from even as early as 1969. So there is an issue of what is dating. And this still continues to come up in terms of where we are in terms of early term versus term and then post-term. And so the group decided to focus on the line of 41 weeks and to use the 39 week as the term gestation to start the clock from. And this required our systematic review group, which included some of the Cochrane group editors themselves, to go back and reanalyze this. So it is a discrepancy if one were to look at them face to face. However, if you were to look at the evidence to decision framework, which I referred to, which some of our participants may not be aware of, they will actually find the details, everything rewritten with just the 39-week focus. I hope that answers your query.
Yes, I think it does. And, I'm really bringing this up because I think that review which said 37 weeks really poked a lot of interest, given the fact that it said that you could reduce perinatal deaths and you could have almost an equivalent rate of C-sections. It seemed to be a very exciting thing. But on the other hand, we have workers of prematurity who say that at 37 weeks, perhaps cognitive development may not be as good as it is after 39 weeks. So I was always a little concerned about this 37 weeks review, whether we are, doing it too early. And I think your answer as to why the whole reframing took place is really very important. And then would it be fair to say that as of now, our benchmark to say that this pregnancy is at term should be 39 weeks and not 37 weeks, irrespective of that review? Would that be a fair remark to make?
I think it's a fair remark to make that we're using 39 weeks and we're using 41 weeks as that mark for the end of term and then post-term. If I may also just mention, I completely agree with you and understand the excitement that came out with regard to this early term, sort of early term induction. And this is where the GDG wanted to make the point that there is this sort of, in some settings, specifically that referring to the trial that was done in the US, if you have high levels of availability for care, there is maybe some benefit for induction early, just at term.
Right.
But this is a very fine line. And so the GDG wanted to make it very, very clear that this is not for everyone and everybody. And I think if you, it may be difficult to see the nuance, but words like routine, regular, it is meant to imply, if I say the entire world globally, it is meant that for the entire world globally, we don't recommend induction at less than 41 weeks. However, the GDG wanted to make the point, it's understood that in very specific cases, with counseling, with understanding of your system's availability and resources, and with very, very detailed counseling on risks and benefits, there is a place for many of the things that we've been talking about today. But those are very specific context issues, and that implies that the provider themselves needs to understand the risks and benefits. They don't need to go into the nitty-gritty of the Cochrane review or the details of each trial. That's why I wanted to take some time to show how they could interpret an evidence-based decision framework. And Dr. Sherry talked about, certainty of evidence. Some of this may be overwhelming for our participants, and they may wish to just understand, what do I do? And I think the what to do is use 41 weeks as a benchmark for post-term. Anything less than that, you really need to be thinking very carefully about your setting and your ability and availability to counsel appropriately on the risks and benefits for the woman. Sorry if I took so long.
No, I think, but that's really very important in the context of that, because, wherever we were giving talks and when we were listening, it almost seemed as if 37 weeks was the new normal for induction, which quite clearly it is not. So I think that's a very important message which needs to go through. Thank you very much, Doris, for that wonderful presentation and that quite clear explanation of why 37 should not be the new 41 or even 39. Preeti, there have been quite a few questions also for you. One is how to combine catheter and oxytocin for cervical rightening. And a follow-up question to that is how to combine a catheter and a dinoprostone for cervical rightening.
So actually, Dr. Jaideep, as we belong to India and we have our own guidelines, because we know there's a vast diversity of infrastructure in the medical health system in India. We have public facilities as well as private facilities, and remotest of the public facilities also as CHCs and PSCs. So what I want to comment on this is we usually follow the Bishop score. That is favorable or unfavorable cervix, a Bishop score less than 5. We prefer giving a cervical ripening with dinoprostone first, and then gel, followed by, if that is not working, with Foley's catheter, and after 24 hours, then sequential use of oxytocin. This is the practical what we are doing in our country, that we give, like if we have a patient with a previous cesarean section, we the first thing would be the Foley's catheter rather than putting a dinoprostone gel. So this is what is the practice here in India. In most of the public facilities, this is how we follow. If a Bishop score is more than 5, we follow modified Bishop score. If a Bishop score is more than 5 or 6, we usually start the induction either with the oxytocin or misoprostol. So this is a recommendation here in India, but whatever WHO has given the recent recommendation, I think the biggest challenge is the implementation of these recommendations in these countries. So this is my take on this. And Foley's, I think, is the safest one and the cheap one. And I think the healthcare workers, what we call as the staff nurses, also can put these catheters easily under the guidance of the health professionals here. So we don't have midwives yet in our country, but mostly the practices are done by either the postgraduates or the doctors. We don't allow the nursing staff or midwives. We have just started, so we are just looking into the wider perspective later on. But I think mechanical Foley's would be the ideal one. And then after 24 hours, if it doesn't work, then followed by that, we give the oxytocin. Yeah.
So I think that, I think maybe you saw the Q&A chat, Preeti, because there was another question as to when will you remove the catheter if the patient doesn't go into labor after 24 hours of induction? I think you just said that.
Yeah, 24 hours followed by oxytocin. We usually give, this is what we are doing as a routine practice.
In fact, just to inform our viewers that we have a state in India called Kerala, and we have Dr. V.P. Paili there, who has published some absolutely astonishing results on the use of Foley's catheter for induction of labor. And, the number of successful inductions that he has, I really don't think I've seen them anywhere else in most literature. And he attributes a lot of that to the fact that he uses the Foley's catheter quite routinely as a method for induction. You have pointed out, Preeti, all the advantages of using a Foley's catheter. And I think sometimes that it was sort of going out of fashion, if I may say so. It was going out of vogue. It was considered to be a low-tech thing. But I think this WHO guidance reiterates its usefulness. And I think
Dr. Jaideep, still, I think Doris will throw more light on this, whether you should start oxytocin along with Folies at the same time in the low dose, or should you wait for 24 hours and again the sequential oxytocin is still, I think I myself is in dilemma, because the practice routine is for the Foley's catheter followed by oxytocin. I would like to have the comments of Dr. Doris on this. And one more, if Dr. Jaideep permit, in gestational diabetes, should we wait for till 41 weeks? That's another question. I'm sorry, Dr. Jaideep, but that was the question that was haunting in my mind, because we have very
very important questions.
Yeah.
But Doris, before you answer that and I come back to you, let me go to Sherry, because I have only around 3 to 4 minutes left. Sherry, the obvious question would be, why do we need to talk about outpatient induction of labor in the first place? Given the fact that, all these years we have been inducing patients in hospitals. What is the reason for this sudden interest? Is it because of a lack of resources? Or is it simply for the fact that patients would be more comfortable at home? And if it is for the fact that patients would simply be more comfortable at home, I would say that counseling about, when to come back, monitoring fetal movements, etc., would be key. Because if you send the patient home, even if it's after a priming and then there is an adverse perinatal outcome, in some countries, this could have medical legal consequences. So what are your thoughts on that?
Yes, thank you for that question, Dr. Tang. I think it's more of our goal also, apart from having good perinatal outcomes, we want to give our patients the best or a positive birth experience. And one of the ways to give them a positive birth experience is to bring some kind of normalcy when they go into labor. So that would be, they are more in control. So that would promote autonomy as well. They are more comfortable. So we really try to do that even in the hospital setting. No, so we try to not place them on NPO. We try to say you can assume any position you want, you can move around, you can eat whatever you want, so that there's some sort of normalcy and she's more satisfied when she goes into labor. But there's still some things that you can do at home which you can't do in the hospital, and I guess they're more comfortable at home, and that's one of the reasons why this came up, the question of whether having them induced at home will have a positive experience on them and will it improve outcomes. But unfortunately, we have very low certainty evidence on that, and we still need a lot of randomized trials or even cohort, large observational studies to back that evidence up. So later on, we'll see. It's very dynamic.
Thank you, Sherry. I think there is another question on the use of evening primrose for cervical ripening. I know a lot of mothers in India like to give castor oil to their daughter-in-laws or daughters to induce labor. And maybe you could just briefly talk about that, and then I'll move to Pisek, who has raised his hands, to, I think, give some inputs on outpatient induction. And then if Dr. Ratnasiri permits, we can ask Doris about the questions which Preeti brought up.
Yeah, so in the Philippines, we usually use vaginal prostaglandins as a cervical ripening agent. And although the evidence is not that robust yet on the use of evening primrose oil, there are small RCTs and even local studies saying that whether you give it orally for 7 days or intravaginally, it can improve the Bishop score. So in the Philippines, we've been using evening primrose oil as well and vaginal prostaglandin. So some obstetricians are wary of uterine tachysystole or non-reassuring fetal status. So among patients wherein you're kind of wary of giving prostaglandins because of those side effects, they start with evening primrose oil.
Thank you, Sherry. Before I hand over to Pisek and then to John for the closing remarks, let me again thank all the 3 speakers. I think the presentations have been quite wonderful, very crisp and insightful. And also thank the chair of the MFM committee, Dr. Ratnasiri, our president, Professor Pisek, the president-elect John, and our very dynamic secretary, Dr. Rohana, for getting this webinar together and asking me to do the Q&A. Pisek, up to you, please.
Thank you very much, Jaideep, and thanks for Doris who reminding me to give this information. My colleagues who is doing his PhD at University of Birmingham, together with the Birmingham group, is conducting a network meta-analysis in this induction of labor. So perhaps within together with Doris and Femi at WHO and the Pregnancy and Childbirth Review Group. So after finishing this network meta-analysis, we will have more information. And I hope at that time, Doris will have another update for us in this induction of labor. Thank you very much, Edith. Over to you.
Yes, thank you very much. I think we could have spent more time on these discussions, but with the time limitations, that's all we can discuss. I think very interesting to discuss over and over what is happening in different parts of the world. So with that, I think we have to thank all the speakers, all who have participated as panelists, and all the participants. And for the conclusion remarks, may I invite Professor John Tate from New Zealand. He has been waiting for a long time with us. I think thank you, John, for joining today with all these time schedules at different time schedules. May I invite Professor John Tate, President-elect AOFOC, to give the conclusion. Thank you.
Thank you very much. A fascinating session, and it really is my privilege to thank our three speakers, Doris Chu, Pariti Kumara, and Sherry-Ann Sopido. I thought their presentations were exceptional, very informative, and were very succinct in talking about the WHO recommendations for the induction of labour. I'd also like to thank the attendees and Dr. Ratsuri and his MFM committee for organising this webinar. Hopefully, webinars like this will help socialise the recommendations, as Doris was hoping for too, because unless we get these recommendations out and using it, we will not necessarily be able to improve outcomes. And the one thing that we are all here for is to improve outcomes for mothers and babies. And as a side effect, and with proper use of induction, we may also be able to optimise caesarean section rates. But just to thank everybody again for the excellent presentation and what I thought was an excellent webinar. Thank you.
So thank you again for all of you. Shall we have only the panelists with us, Rajit? Shall we disconnect the participants?
Thank you. Thank you.
Thank you very much.
Thank you very much. Thank